Hello everyone, welcome back to ComMed Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. Today's topic of discussion is Randomized Control Trial or RCT, which is one of the experimental study designs. So if you remember the classification of epidemiological study, on one side we have observational study and on the other side we have experimental or interventional study. Under the experimental study arm, we have randomized control trial along with field trial and community trial. So the question is when to use an experimental study design. So it is based on two questions. First question, we have to see if we are studying the efficacy of a therapeutic procedure, for example any drug, surgical procedure, etc. Or if we are studying the efficacy of a preventive procedure like vaccine, serum, chemoprophylaxis, personal protective measure, exercise program, etc. Or if you are looking for the efficacy of healthcare system or procedure, for example domiciliary versus institutional care. Now if the answers to these questions is yes, then we should proceed to the second question. The second question is if we can randomly divide the subjects into two groups, one getting the intervention and the other group either not getting any intervention or getting a different kind of intervention. So if this random allocation is feasible or if it is ethical. So if the answers to this second question is also yes, we can go for experimental study. If the answers are no, then we should better go for any analytical study, which is either case control or cohort study. Based on randomization, experimental studies can be of two types. Those studies which involve process of random allocation are known as randomized control trials or RCT. Today we shall discuss RCT in details. There are certain studies where random allocation is not possible, and this non-randomization does not seriously affect the theoretical basis of conclusion of the study, and this kind of studies are known as non-randomized trial. These are the different steps in conducting a RCT: drawing up a protocol, selecting reference and experimental populations, randomization, manipulation or intervention, follow-up, and then assessment of the outcome. This is the flowchart of an RCT. We shall discuss individual steps in details. First is the protocol. Not only RCT, but any kind of epidemiological study should be conducted under a strict protocol. A protocol specifies the aims and objectives of the study, the research questions which will be answered in the study, different criteria for selecting the study group and the control group, that means those people who will receive the intervention and the people who will not receive the intervention or may get any different kind of intervention, sample size or number of study subjects to be included in the study, how we shall allocate the subjects into study group and the control group, what kind of treatment to be applied, when it is to be applied, and how to apply this treatment, standardization of working procedures, responsibilities of the parties involved in the trial. So everything is included in the protocol. Once the protocol has been made, we should always stick to the protocol until the study ends. Sometimes what happens, before the actual study begins, we conduct a preliminary test, also known as pilot study. The purpose of the pilot study is to find out the feasibility or operational efficiency of certain procedures that will be included in the study. Also, the acceptability of these policies to the study subjects. If we find any difficulty, we can modify our protocol accordingly, and once the protocol is finalized, we shall stick to that protocol until the study ends. The next step is selection of reference and experimental population. So reference or target population is the population to which the finding of the trial, if found successful, are expected to be applicable. So after conducting the RCT, Whatever are the findings, those findings should be applicable or can be generalized to this reference or target population. Now, if you remember from my other videos, I already mentioned that it is not always possible to conduct a study on the whole population, a population that is big. So what we do, we take a selective number of people who are representative of the population. These people are called the sample. So we conduct our study on the sample population, and then whatever are the result, we can extrapolate the result on the larger population. So same thing happens here. We have the experimental study population. The study population is derived from the reference population. So they are basically the representative of the reference or target population. It is the actual population that participates in the experimental study. So we take some people from the target population on whom we conduct our study. This is known as the experimental study. After conducting the study, whatever are the findings, we can say these findings can be generalized or applicable to the reference or target population. So this is the concept. There are certain criteria that the study subjects must fulfill before participating in the study. First one is they must give informed consent. So without their permission, we cannot take them in our study or include them in our study. They must be fully explained about the purpose of the study and the procedures of the study, and also the possible side effects or difficulties he or she may face during the study. And only after that, if the person gives us consent that he wants to participate in the study, we can include them in our study. They should be representative of the population to which they belong, that is the reference population, and also they should be qualified or eligible for the trial. The third stage is randomization, which is often known as the heart of a randomized control trial. Randomization is a statistical procedure by which participants are allocated into groups, usually called the study or control groups, to receive or not to receive an experimental, preventive, therapeutic procedure, maneuver or intervention. So what does it mean? So it means it is a statistical procedure by which the participants or the study subjects are allocated into either study group or control group. Study group means those people or those subjects who will receive a particular intervention, and control group means those study subjects who will not receive that particular intervention, or maybe they will receive a different kind of intervention. So this allocation of the participant into either study group or control group occurs randomly using a statistical procedure. This is known as randomization. Randomization ensures the investigator has no control over the allocation of the participants to either study or control group. That means the researcher or the investigator himself cannot decide whether a participant should be put in the study group or the control group, because it occurs randomly using a statistical software, and by that we can eliminate the probability of selection bias. It is crucial that both the groups should be alike with regard to certain variables or characteristics. So in my previous videos I mentioned about confounding factors and some variables which can influence the outcome of a study. So if these variables, for example age, gender, etc., are unequal between the study group and the control group, they can actually distort the result of the study. So that is why we must ensure, or rather we should try to ensure, that these other variables or certain variables are similar in the study group and the control group, and by that we can eliminate the effect of these variables on the result of our study. Now if we remember from the classification of epidemiological studies, in analytical studies, for example case control and cohort study, there also we compare between groups, and also in RCT we compare between groups, right? So what is the difference? We have to understand that only in case of RCT there is a scope of randomization. In case of analytical studies like case control study or cohort study, there is no scope of randomization. So that is the main difference between analytical study and randomized control trial. So what are the different type of randomizations? Here I have mentioned only 4 types: simple randomization and stratified randomization. These two are the types that we shall discuss today. Block randomization, covariate adaptive randomization, and there are many more which are very complicated methods, and it is beyond the scope of the discussion in our channel because these are not at all important for undergraduate students. First one is the simple randomization. It is the simplest method. We can do coin flip, or we can also roll a dice. Suppose we want to conduct a RCT and we want to compare two treatments, treatment A and treatment B. We have to decide which subjects will be included for treatment A and which subjects will be included in the group for treatment B. So we can do a coin flip. If the result is head, we can include that participant in A group or treatment A group. If the result is tail, we can include that subject in treatment B group. Similarly, we can also roll a dice. If the result is in odd number of dots, that is 1, 3 and 5, maybe the subject can be put in the treatment B group. Whereas if the result is either 2 dots or 4 dots or 6 dots, maybe we can put the person or the study subjects in treatment A group. So this is simple randomization. But remember, what is the problem of this simple randomization method? This method does not address the other variables which can have influence on the study outcome. To address that, we can go for stratified randomization, where we stratify the study subjects according to different variables which can have influence on the study outcome, and then we select our study subjects from individual strata. Let me give you an example. Now suppose I want to compare a new treatment with an existing or current treatment. So for that, what I can do is I can gather 1000 patients of a particular disease and then do simple randomization and divide them into 500 people receiving the new treatment and 500 people receiving the current treatment. Now if we look closely, there are probability that there are certain mistakes or rather problems with this simple randomization method. Maybe there are more number of male subjects in the new treatment and more number of female subjects in the current treatment. Also there is another probability that there are more number of younger population in the new treatment, whereas more number of older population in the current treatment. So as you can see, the gender, that is male and female, as well as the age group, that is younger population and older population, they are different between the two groups of treatment. So if these variables like gender, age have any influence on the outcome of the study, the results that we shall get from this RCT will be false. So that is why it is very important to address all these variables which can have influence on the outcome of the study. So for this, it is better to go for stratified randomization. So as you can see, first we have stratified the study subjects by gender or sex. So maybe out of 1000 patients we had 600 males and 400 females. Next step is stratify these males and females according to age group. So maybe out of 600 males we have 360 younger males and 240 older males, right? Similarly, out of 400 females, maybe there are 300 younger females and 100 older females. So now we have 4 different groups. Okay. Next, we can divide each group equally into new treatment group and current treatment group. So we have 360 younger males here. So we can divide them as 180 here and 180 here. Similarly, 240 older females, so 120 here and 120 here. 300 younger females, so 150 here and 150 here, and 100 older females, that is 50 here and 50 here. So if we add them up, we have 500 subjects in the new treatment group, 500 subjects in the current treatment group, and if you look at them closely, you will see the number of male and female as well as the age group will be similar in both the treatment groups. So by this we could nullify the effect of gender as well as the age group on the outcome of the study. So this is why it is better to go for stratified randomization, by which we can address a lot of other variables. The next step is manipulation or intervention. In randomized control trial, we can compare between different interventions. For example, we can compare one drug with another drug, or maybe one surgical procedure with another surgical procedure for a particular disease. We can also compare one vaccine with another vaccine in prevention of a particular disease. Say we want to compare between Covaxin and Covishield. So we select a large number of people and divide them into two groups. One group will receive Covaxin and another group will receive Covishield. Then we have to follow them up for a certain period of time, and at the end of the follow-up, we shall assess which group have developed more number of COVID patients, because you have to understand that even after taking vaccine, we still can develop the disease. So the group where the number of COVID patients are less, we can say the efficacy of this vaccine is better. Now it is a lot more difficult and complicated procedure, but to simplify this thing, we can say that number of patients, COVID patients developing in a particular group, if it is lower than the other group, then that particular vaccine is probably have higher efficacy as compared to the other vaccine. So this is manipulation or intervention. Next is follow-up. As I mentioned, after giving the intervention, sometimes we give two different drugs in two different groups. Sometimes we can also give one drug to a group and another group we give placebo. So whatever it is, after giving the interventions, we have to follow these subjects for a particular period of time. This time may be short, and sometimes this may be many years. So if it is a long duration study, that means the follow-up period is very long, there is problem which is known as attrition, because sometimes what happens, a lot of the subjects may leave the study before completion, or maybe some of the subjects can also die because of any other reason. So this is known as loss to follow-up. So that means we are going to lose a significant number of subjects from our study when the study ends. Ideally, during this time of follow-up, the subjects should be examined at a interval of time. That means they should be assessed in a standard manner with equal intensity. That means both the group of subjects should be assessed with equal intensity following a standard procedure. Okay, it is not that we should give preference to one particular group of subjects and assess them with higher intensity. It is not like that. It should be done with equal intensity for both the groups. The last step is assessment of the outcome. So this is the final step, and it can be either positive result or it can be negative result. Positive result, that is benefits of the experimental measure, such as reduced incidence or severity of disease. So if any particular vaccine causes a reduction in incidence of the disease, or if any particular treatment reduces the severity of the disease, cost to the health service, maybe this particular procedure actually reduces the cost of health service. So all these things are considered as positive results. What are the negative results? Most often, when you compare between two drugs, the side effects, the complications from the drugs or treatment or intervention are considered to be the negative results. Also, death is considered to be the negative result. So again, we have to consider both positive results as well as the negative results when we are comparing between two different interventions. So maybe if we are comparing between two different drugs, right, we see that this new drug, it has better positive result because it is curing more number of patients. All right, also it is probably cheaper as compared to the other drug. So apparently this drug is better than the existing drug. But if we look at the negative result, maybe there are a lot of side effects from this new drug. So that means this is also unacceptable for the subjects. So maybe on this basis, this new drug may not be acceptable. So that is why we have to consider both positive results as well as the negative results. So these are the different steps of RCT. Now coming to different bias in RCT, the first one is on the part of the participants. If a participant knows which intervention he is receiving, his perception regarding the outcome may vary. For example, if you are comparing between a new drug with an existing gold standard drug which actually works in a disease, suppose the subject or the participant knows he is receiving the new drug. That means he also knows he is not receiving the gold standard drug which actually works. So he may feel that since he is not receiving the gold standard drug, he is probably not getting better. So he will tell the investigator or the researcher that he is not feeling very good, he is not improving. That means his perception regarding the outcome changes because he knows he did not receive the gold standard drug and he received the new drug. So this is known as subject variation. The second one is observer bias. Here the observer or the researcher or the investigator also knows which subject received which intervention. Maybe he also thinks that the gold standard drug probably works better. So he is already biased in his mind. Now when he will measure the outcome of the therapy or the trial, he will do this assessment with higher intensity among the people who received the gold standard drug, while he will do this assessment with lesser intensity among the new treatment group of subjects. Here I already mentioned this assessment should be done with equal intensity. You can see here, but here he violated that concept and his assessment was of different intensity between the two different groups. This is because he already knew which subject received which intervention. This is known as observer bias. There is a third possibility, that is the bias in evaluation. This is quite uncommon, but this is also very much possible. The person who is responsible for analysis and evaluation of the trial, if he knows which subject is receiving which treatment or which intervention, then there is a possibility that he will subconsciously give a favorable report of the outcome of the trial. Alright, so this is known as the bias during evaluation. Again, this is very uncommon, but this is possible. Now, to address all these bias, we go for blinding or masking. Alright, there are three types of blinding: single blinding, double blinding, or triple blinding. What is single blind trial? These are the trials where the participants or the subjects are unaware of which intervention they are receiving. In double blind trial, the subjects or participants as well as the researcher or investigator are unaware. And in triple blind trial, the subjects or the participants, the investigator or the researcher, as well as the person who is responsible for analysis and evaluation, all of them are blind. Ideally, triple blinding should be done, but most commonly double blinding is followed in different randomized control trial. Now there are two different study designs of RCT: the concurrent parallel study design that we discussed so far, and the other one is crossover type of study design. So if we go back to the flowchart that I showed earlier, this is the concurrent parallel design. So we have to select the suitable population, which is the reference or target population. Since this target population is so big, it is not possible to conduct the study on all the people in this reference or target population. So what we do, we select a suitable sample, which is known as the experimental study population, because we are going to conduct our study on this sample. Now some of them may not be eligible for the study and some of them may not be willing to take participation in the study. So they should be excluded and the remaining number of subjects should be randomized into experimental group and the control group. Alright, or better to say first intervention group and the second intervention group. After creating these two groups, we manipulate or do the intervention. So this group receives the first intervention, this group receives the second intervention. Then we follow up, and after the follow up we assess the subjects for the outcome of interest in terms of positive as well as negative results. So this is concurrent parallel design. The other type is crossover type of study design. Now this is the type of study design where each patient serves as its own control. So if you remember, I mentioned earlier, there are certain variables which can be different between two groups of intervention, and these variables can have some influence in causation of the disease. So if these two variables are different in two different groups, the result of the trial may be biased or may be wrong. To address this, it is better if we compare within individual group rather than between the two groups. So that is possible by crossover type of study. There are a lot of things written here in this slide as well as in this slide. I will recommend that you pause these slides and have a read, but I shall go directly to the example page, and I hope this will be easier for you to understand. In this example, we have tried to find out whether amlodipine or losartan works better in hypertension. So the disease is hypertension and the two different modalities are amlodipine and losartan. So we have two different groups of people, group 1 and group 2. All of them are hypertensive, and at the beginning of the study we measured their blood pressure. Now group 1 of subjects are started on amlodipine and group 2 on losartan. So remember, pink color is amlodipine, yellow color is losartan. Alright, suppose after 1 year we measure their blood pressure again, and we try to find out how much blood pressure has decreased in the subjects of amlodipine group and in the subjects of losartan group. The next thing is we have to switch the group to the other treatment. That means people who are receiving amlodipine so far will be switched to the losartan group, and people who are receiving losartan so far will be switched to the amlodipine group. But there is something very important that we must take care in this stage. So after 1 year of treatment, when the blood pressure was measured again, the drugs should be stopped. So these people who are receiving amlodipine should be stopped here, and here the losartan should be stopped. Then we have to give some time interval or gap before we do the switchover, because we must allow the system of the subject get rid of all the medicines or drugs, so that whenever the subject is taken to the other group, there is no residual effect of the previous treatment in his system. Alright. So since after this period of time, when switching over is done, that means people from one group is included to the other group, and also people from the second group is included to the first group. This is known as the crossover design or crossover type of study. And this time gap that we are giving is to avoid the carryover effect of the drug when he is introduced to the other treatment. So now people who are receiving losartan earlier have come to the amlodipine group, and people who are receiving amlodipine earlier have come to the losartan group. Again, we have to measure their blood pressure before initiating the study, or rather initiating the treatment, and then this group of people will be started on amlodipine, and this group of people will be started on losartan. Alright. Maybe after another year we shall measure their blood pressure and try to find out how much blood pressure decreased in this group 2 people who are now receiving amlodipine, and in this group 1 people who are receiving losartan. Now look at this. Comparison is done between the people in a single group. See here, the group 1 people, when they did not start amlodipine and when they completed 1 year of amlodipine, we have to measure how much blood pressure was decreased. Similarly, the same group of people before starting the losartan and after continuing the losartan for 1 year, how much blood pressure decreased here. So this decrease in blood pressure is compared to this decrease in blood pressure, and we are comparing this. So that means only the subjects of group 1 are being compared between themselves. We are not comparing subjects of group 1 with subject of group 2. Since the same group of people receive two different treatments, we can compare the outcome of two different treatments in the same group of people. So here the blood pressure decrease was due to amlodipine, and here the blood pressure decrease was due to losartan. With this, since they are the same group of people, whatever are the status of other variables in terms of gender, age group, occupation, whatever, they can be ignored because they are the same people. Alright, so the only difference here is the treatment they received. Similarly, here also the group 2 people who received losartan, here how much blood pressure it decreased, it can be compared to the blood pressure decreased due to the amlodipine, the same group of people. Alright, here also we can ignore the effect of the other variables because the only difference is the treatment they received. So this is known as the crossover type of design because group of people, they are crossing over to the other intervention after receiving first intervention, and the comparison is not with the other group of people but among the same group of people but with two different interventions. So that is the advantage of this particular study type. Coming to ethical consideration in clinical trials, the first principle is that if our study or trial involves certain interventions which can be harmful or hazardous to the health of the subjects, then it is better avoided. That means this kind of studies or trials are not ethical. Principle 2 is no human being should be denied a treatment or such other intervention which is known to be effective for the particular disease. So if you are trying to compare between drugs, or rather we are trying to know whether a particular drug works in a particular disease, sometimes what is done is we give that new drug or particular drug to a group of people and the other group of people is given placebo. Placebo means fake drug. That means these are the things that does not work. So that means we are depriving or denying treatment to this other group of people who are receiving the placebo, even though there is existing treatment available for that disease. So this is also unethical. Okay. Confidentiality, that means all the informations that we gathered from the participant should be kept confidential and also should not be made public. Principle 4 is informed consent. That means all the subjects have the right to know about the purpose of the study, the details of the procedure of the study, that means what we are going to do in our trial, and also about the probable side effects and complications that can arise from our trial. So after knowing all these things, if the subjects still want to take participation in our study, that means after having the informed consent, we can include them as study subjects for our trial. Principle 5 is no incentives or pressure. That means the subjects should not be offered any kind of monetary benefit or any materials or kinds just to participate in our study. It should be voluntary. Principle 6 says that if there is any harm which resulted from the trial, then it should be taken care of. Treatment should be provided and compensation should be made. For example, if the study subjects of our trial, they are daily wages, that means they have to go to work daily and they will have their earning and they can have their food on that day, right? So that means their livelihood depends on daily earning. So if they take participation in our trial, that means he could not go for the for his work on that particular day. So for that reason we may have to give them compensation so that he can eat or he can provide for his family. Principle 7, the people who will be conducting the trial should be adequately qualified and also competent to undertake the trial. Principle 8 says whatever are the benefits and the burdens or research or the epidemiology should be distributed fairly. This means the helpless or the people who do not have any voice, they should not take all the burden of the epidemiology, as well as those people who have the power or in better position should not take all the benefits. It should be distributed equally. Principle 9 says the participants should be informed of the information which has resulted from the research. So suppose in a particular trial we have found out that a particular drug works better as compared to the other drugs. So all the subjects who have taken participation in the study have the right to know which drug works better. So they should be told about that. So all this information can be given to them as much as it is permissible. And principle 10 says, if ideally any research on animal should be avoided, but if it is absolutely necessary, then you should be done. And if it requires any sacrifice of animals, it should be done in human manner. So with this we concluded RCT. Please subscribe to our channel, like the video, share this video with your batchmates, with your juniors, and also with your friends from other colleges. We also have our Facebook page. The link is given in the description. You can follow our Facebook page also. So take care, and we shall see you in our next video.